Hello and welcome to the Neuroendocrine Cancer UK Q&A session on the subject of high-grade neuroendocrine cancer. This series of Q&A sessions has been created as part of the Neuroendocrine Cancer UK Virtual Patient Handbook, which is due to be released in 2023. My name is Beth and I will be hosting these sessions with various medical experts covering a range of questions within neuroendocrine cancer care. Although I have worked with Neuroendocrine Cancer UK for a little while now, I'm not a medical professional myself, and so in many ways I'm learning alongside you, the audience. Some of the questions I'll be asking have been taken directly from the neuroendocrine cancer community, and the focus of these sessions will be on providing useful information and advice in a concise audio-visual format. In this session, Professor Nick Reed will be answering a range of questions on high-grade neuroendocrine cancer. But firstly, let's get to know him a little better.
My name is Nick Reed. I'm a consultant clinical oncologist based at the West of Scotland Neuroendocrine Tumour Service in Glasgow. I'm just one of the team, and I happen to be an oncologist, but the team is made up of many different specialties. And around the country, you may find that the teams are led by other specialties. My background is that I've been treating neuroendocrine cancers for probably around 30 years. I have been involved in the UKI Neuroendocrine Tumour Society. I was one of the founder members. And in the early part of the 2000 first decade, I was the chairman of UKNETS. Most recently, I've been involved with ENETS, the European Neuroendocrine Tumour Society, and I sit on the advisory board. I also have the honor of chairing the abstract committee. So all the abstracts that are submitted for the annual publication, I'm involved in reviewing them and working with a team that selects the abstracts that are presented at the next conference.
That's great. Thank you. So I think we should just get started with questions. So the first one is, what is high-grade disease when it comes to neuroendocrine cancer?
Well, to answer that, I'm going to be like a politician and answer something else first, but I think it's important to understand where we're starting. We now, at the moment, we talk about neuroendocrine tumors and neuroendocrine carcinomas. And neuroendocrine carcinomas are at the higher end of the spectrum, and they're going to be lumped together under the title of neuroendocrine neoplasms, NENs, known as NENs. And NENs will be divided into low-grade tumors, neuroendocrine tumors, which are generally grade 1 and grade 2. This is looking at the pattern of the cell, how much it is distinct, how different it is from the parent cell. So a well-differentiated tumor will be a grade 1. As it becomes a little more aggressive, it may be a grade 2. And there are various scoring systems that we use to determine that. And then higher grade tumors are known as the grade 3, and we call these neuroendocrine carcinomas. Now, to make things further more complicated, we've introduced another term, what's called a G3 net. And this is sort of somewhere in the middle. It's a little bit worse than a neuroendocrine tumor, but it's not as aggressive as a neuroendocrine carcinoma. And there are big differences in the way it's treated, and there are big differences in the way it responds to treatment as well, a much better prognosis. So neuroendocrine carcinomas then generally will be determined by this the grade, by looking at it under the microscope and looking at the appearance of the cell. In addition, you look at the number of dividing cells, and from that you can get a score known as the Ki-67 or MIB index. And generally, the true high-grade tumors will have a Ki-67 score of over 55%. In reality, the really aggressive high-grade neuroendocrine carcinomas are more likely to have a Ki-67 greater than 70 to 80% and may even reach up to 95 or 100%. But they are distinguished, and this is where it's so important to have a specialized neuroendocrine tumor pathologist who is familiar with the grading system. Because each year I do see a number of patients where, with hindsight, they have been incorrectly graded. And they're usually patients who you would have thought had a very poor prognosis and are still alive. And when you go back and look at this Ki-67, you find it's actually much lower, and they fall into these G3 net. I find it very confusing, because what's the difference between a tumor and a carcinoma, let alone a neoplasm? And a lot of this is purely semantic, and it's the fact that around different parts of the world, the way the English language is used, if like is used flexibly.
So actually sticking on the theme of terminology, our next question is, what's the difference between terminal and incurable?
Another very difficult question to answer, because everybody will have a different definition of what is terminal. My personal definition, or the way I interpret it, is terminal is when you've probably reached the point where no active oncological treatments can be offered. So really you are looking at palliative care or best supportive care. You've exhausted all the therapeutic options that may have an anti-cancer effect. That doesn't mean to say you can't use steroids, anti-sickness drugs, painkillers, whatever you need that's going to help improve the quality of life, but it's not going to extend the quality of life. Now, the irony is with neuroendocrine tumors that there are many patients who have a well-differentiated small intestinal neuroendocrine tumor that may have liver metastases at the time of diagnosis. And some of these, or many of these, will be incurable. Although actually this has all changed in the last few years, because if you have a small number of liver metastases with aggressive surgical approaches and with radiofrequency or microwave ablation, you can actually tackle these. But I have really quite a substantial number of patients under my care who have lived with liver metastases for 15 or 20 years. So they're not curable, but they have lived. And these patients are still enjoying a very good quality of life. And I would anticipate that with modern treatments, many of these patients may live 20 to 30 years. There's a subgroup that behaves very differently. And there are, sadly, some that don't follow such a benign course. And there are some patients that may only live 3 to 5 years. If we go back 10 years, we would generally say somebody who had advanced disease, a well-differentiated low-grade tumor, you might be lucky to get 5 years with treatments. But with modern treatment approaches, even with metastatic disease, low-grade, we would expect patients to live 10 years plus. The introduction of Lutathera, for example, has transformed things. When it comes to high-grade tumors, we're very different. And a true high-grade tumor has a much worse prognosis. And sadly, unless they are localized and limited and suitable for surgical resection, the vast majority of patients will live relatively short times, particularly if they have metastatic disease to the liver. The prognosis can often be 12 to 18 months. So the patients may have a good response to the initial chemotherapy, but it's often short-lasting, may only last 3 to 6 months. And if the tumor recurs, then the chances of second-line chemotherapy working are pretty slim. And sadly, with a metastatic, true high-grade carcinomas, the patient's life expectancy can be as short as 18 months. The only exception to that may be and they're a relatively small number, patients who may have a very localized tumor maybe in the rectum, or the other common site of them is the esophagogastric junction, where the gullet meets the stomach, and in the stomach itself, where very occasionally you may find one that is truly localized. And sometimes these are just picked up by chance. And these are the lucky people, because they're the minority who may actually be cured. When we're looking at the low-grade neuroendocrine tumors, then there's a vast difference between terminality, if you like, and curability, because patients with low-grade tumors may have advanced disease very commonly, but they can live for years. Now, I think what you're getting at is for the high-grade tumors, because so often they are metastatic with liver secondary tumors, then they are going to be incurable. But if it's a new, I mean, you wouldn't, very rarely would you say to somebody, oh, you're a newly diagnosed patient with a stage 4 high-grade neuroendocrine carcinoma. Unless the patient was very frail or very unfit or had comorbidities, you would almost always offer them chemotherapy with platinum etoposide combinations. And you do get surprises, and you will get a few who will get longer lasting remissions. And even occasionally some I can think of a small number of patients over the years who've never relapsed. If you can control the disease, then obviously you control the symptoms, and that improves the quality of life. So the aim would be, in the vast majority of cases, to recommend treatment, and the experienced oncologist will know how to phrase that and how to bring out the pros and cons of treatment. Yes, there are pros, but equally you have to stress that there are toxicities, and sadly, even if the patient has a remission, that the likelihood is that within 3 to 6 months, many of them will relapse. Now, the hope for the future is that we may find some treatments that we can use to try and reduce the risk of that recurrence. But at the moment, adjuvant or maintenance treatments have not yet established themselves. But in principle, some of the newer chemotherapy agents, maybe the tyrosine kinase inhibitors or perhaps the checkpoint inhibitors, that's where they may have a role.
So sticking with terminology, could you describe the main differences? I think you already have begun to actually, but the main differences between neuroendocrine carcinomas and neuroendocrine tumors, and then also the neuroendocrine neoplasms as well.
NENS is just the overarching term, if you like, that incorporates the NETs and the NECs. So NET for the tumor, NEC for carcinoma. I mean, since this is really about the higher grade tumors, what distinguishes them then initially is the pathological appearance. So for the histologist or the histopathologist looking at these tumors under the microscope, he or she will identify a distinctive pattern and will be able to report back to the MDT that this is a NEC, neuroendocrine carcinoma. If it is a NEC, then the management will be very different. And if it hasn't been done, then probability is something like an FDG PET scan will be done. Whereas with a lower grade tumor, you're more likely to do a gallium dotatate PET. Now, arguably or controversially, when you get a G3 NET, you may want to do both. And there are some centers who will do FDG PET and gallium PET in all their cases, because they believe it gives additional information. The purpose of these scans is for staging, but also to look for functionality. And the importance is that generally high-grade carcinomas, neuroendocrine carcinomas, will be negative on the gallium PET, or will have low levels of avidity, or often mismatching. So you will see that much of the tumor will be avid on the FDG PET, but there may be different bits and a fewer amount that are positive on the gallium. But if there happens to be a lot of gallium activity, then potentially that means that treatment with Lutathera could be considered. Now, strictly it's off license and a G3 NET or a NEC, but there are, in some parts of the world, it is available and can be used. So the treatments, with at low-grade tumors, you're more likely to be looking at somatostatin analogs as the first treatment. And then there may be other treatments like hepatic artery embolization and obviously PRRT, Lutathera. But in the higher grade, generally you would go straight into chemotherapy with a platinum and etoposide combination. Generally, again, it's arguable, and in fact, there's going to be a paper coming out from the ENET's guidance, one of the ENET's guidance papers early this year, which addresses this. But for most people, a platinum etoposide is the first choice of chemotherapy. One or two other drugs are being looked at, irinotecan, oxaliplatin in combination, but I think the overwhelming majority use the platinum etoposide. This is the drug combination that's used in small cell lung cancers, which are kind of the, if you like, it's the big brother, the even more aggressive tumor. Because for the majority of these high-grade neuroendocrine carcinomas are known as large cell tumors to distinguish them from small cells. And many people, if not most people, would say that small cell cancers are not really neuroendocrine. They're generally treated by different specialist groups, and they'd have a very different prognosis and management.
Because, like you were saying, that it's interesting that neuroendocrine carcinomas sometimes benefit more from tests and treatments that are used in more commonly known cancers, such as chemotherapy. So is there kind of a simple way to explain why that is with the high grade, with the carcinomas, why you use chemotherapy more often than?
Yes. Well, in general, low-grade tumors, because they're relatively slow growing, they're a low mitotic rate, they tend not to respond to chemotherapy. There are some exceptions, and drugs like temozolomide may be useful, particularly in patients who have MGMT deficiency, but also everolimus, the mTOR pathway inhibitor, has been shown to be active in a subgroup of patients with low-grade tumors. But by and large, traditional chemotherapy is, I would say, disappointing. The one or two centers around the world have claimed higher rates of response with streptozotocin-based regimens, but I would say probably no more than 25 to 30% will get a benefit. Whereas with a high-grade neuroendocrine carcinoma, the paradox is that you get very good response rates. In other words, you can see shrinkage of the tumor very commonly. 70, 80% or more of patients will get a shrinkage of their tumor, but the duration, in other words, the length of time the tumor remains in remission, is commonly no more than 3 to 6 months.
Okay.
And that's the difference. And that's really why at present they're so difficult to treat.
So could a patient's neuroendocrine cancer become high grade in the future if it isn't currently, or if it isn't in the beginning?
Yes, the answer to that is undoubtedly yes. And most of us will have seen anecdotally a few patients who we've been looking after for 5, 10, 15 years, where suddenly something goes wrong. The first clue might be a dramatic rise in the chromogranin A, which may lead to a scan showing an aggressive change. But of course, what has now also come into play, and this just goes back to what I was raising a few moments ago, is the use of the PET scanning. So you will find that in a low-grade tumor, generally it's the gallium dotatate PET that is done, and that shows avidity in the vast majority of cases. But as the patient's disease transforms, then they may switch, and in other circumstances called flip-flop, but they may flip from being gallium avid to gallium poorly avid, and they become FDG PET avid, whereas previously the FDG PET was negative. And this is one of the reasons why there are a number of centers that now recommend, if you've got the luxury of being able to access this, that you get both PET scans done. And there are many people now have examples where you can see this transformation. Quite often it's a more gradual, and it's picked up because you happen to do the two imaging modalities. But there will be the occasional patient where you will see a rapid change. And I had one last year, or very sadly, a guy who had been really sailing along, doing very nicely. And in the course of 3 months, he went from performance status of 0 to performance status of 3. And although we did try chemotherapy, it was always 2 steps ahead of us. Luckily, they are unusual still. But of course, as patients live longer with low-grade tumors, we may in the future see this happening more frequently. And hopefully we will be able to treat them. But at the moment, it happens, but it's not common.
Okay. But it obviously highlights the importance of surveillance.
It highlights the importance of being looked after by a specialist team who, would know, are familiar with how these tumors can progress, and to look for any herald signs, any signals that something may be changing. And if you may be able to nip in, as it were, and start a treatment before a significant transformation has occurred.
So our next question is related to how a diagnosis is described. So, for example, when a patient is told they have advanced cancer, does that mean automatically that it is high grade?
Not at all, no. As it is well recognized that particularly for small bowel and some pancreatic tumors, these patients with low grade, well differentiated neuroendocrine tumors, a high proportion will have liver metastases at the time of diagnosis. So that is advanced. We can debate whether they have lymph nodes, whether we call that advanced or whether we call that loco-regional. But let's just focus on the fact that a high proportion, or a fairly high proportion, will have liver metastases at diagnosis. But many patients, particularly with current treatments, can live 10 years, 15 years, possibly even longer. But this is very different for a high-grade neuroendocrine carcinoma with liver metastases, where sadly the likely prognosis is going to be substantially under 2 years, quite often 12 to 18 months. You get the exceptions. There are some who seem to have some biologically different trait, or you happen, maybe in the future we'll identify they've got some genetic, at the cellular level, there's a genetic change which allows them to respond better to treatment. But at the moment, we have to assume that the majority of high-grade advanced tumors will not be cured, and it is palliative chemotherapy that they're getting.
Yeah, that you kind of touched upon quite an interesting point, really, in terms of I guess genomics, really, isn't it? How we're all going to be responding to things in different ways, and as we learn more about that area, we can start to see
Yes, the next 10 years, I think we'll see. And then, what we've seen in the last 10 to 15 years has been extraordinary. But my prediction is that the next 10 to 15 years, we'll see even more remarkable developments in how we diagnose tumors. The neuroendocrine tumors are a wee bit behind the rest of the world as well. But if you compare us with, say, lung cancer or colorectal cancers and breast cancers, where they have molecular profiling which is established and is useful, we still don't have. We're playing catch up fast, and the good news for us, I suppose, being behind, we don't have to go through all the basic experiments that the previous researchers did, so we can adapt their technologies, as it were, and that's why I think within 5 to 10 years, when a patient comes in and have a biopsy, at the moment, for the majority of cases, we're just getting what's called a histopathological diagnosis. But in the future, you'll get a molecular profile, and this will, give you a list of the things that are likely to, the kind of treatments that are likely to work, or equally the types of treatments that may not work. Because many of these drugs are extremely expensive, and what you don't want to do is to use a treatment futile in a futile manner. It's not good for the patient to get a treatment where the chance of response is very small, and equally it's not good for the NHS to be spending, because many of these drugs are £1,500, £2,000 a month, and if you're going to give 6 months treatment with no benefit, that may be £10,000 wasted, and you could be looking at better ways of using that. So I think for the future, that will be the way we plan our treatments. We're not quite there yet. Some of the other tumors are ahead of us, but we're playing rapid catch up.
That's interesting, that point that you made about kind of us being behind is not always a bad thing, in terms of being able to kind of stand on the shoulders of the giants kind of idea, isn't it, where you're using other research. So I understand you've been quite active in clinical trials through the UK and Ireland Neuroendocrine Tumor Society. It seems appropriate now then that my penultimate question is about trials and research into treatments for high-grade neuroendocrine cancer. Are there any updates you can tell us about that are of note?
Yeah, so I mean, most of the studies are at the moment involving sort of early phase two clinical trials and some phase one. The UK actually has recently carried out a study led by Mairead McNamara from Manchester called the NETO-2 study. And this was actually quite a large phase two trial, because obviously neuroendocrine tumors that are advanced are relatively infrequent. So getting patients into trials isn't always easy. And there is a dearth, or there has been a dearth of trials. And of course, the COVID hasn't helped all that. So the UK has been, the UK and probably Spain are sort of very much at the forefront of this. And we're quite lucky. There's a lot of European collaboration. Yes, we will obviously try and consider clinical trials whenever they're available, but unlike lung cancer, breast cancer, bowel cancer, there are far fewer trials available. Many of the studies at present are either what we call investigator-led studies. And in other words, it's an investigator will come up with an idea and go to a drug company and get some limited funding, or else they tend to be supported by pharmaceutical companies. And that obviously means that they dictate what happens, and they can also dictate who goes into the trial. The UK, I'm sorry to go political now, but the UK, of course, has shot itself in the foot with Brexit. And this has meant that particularly European collaboration has become more challenging. It's not completely stopped it, but we have disadvantaged ourselves. And so whereas our friends and colleagues in Spain and Germany, Italy, France may have clinical trials, there are much bigger challenges in working with them because of, as a consequence of Brexit. But clinical trials, very important. That's how we learn. That's how we go forward. At the moment, though, there are a relatively small number that are open, and a lot of them are only open in a limited number of centers as well. But I think as a patient, you should always say, is there a clinical trial open? You know, is this, because you may benefit by getting something that's not otherwise available or funded. So I always encourage patients to say, you know, to ask. You've got nothing to lose by asking. So do ask your oncologist. He or she won't be or shouldn't be upset if you ask them. It's a perfectly fair question. You know, is there a trial? And sometimes patients say, "Look, I'm willing to travel." Particularly if, you know, some of the trials recently have only been open in 5 or 6 centres in the UK. And they try to get a geographical distribution. But sometimes it can mean patients having to travel. And if they're willing to do that, then that's great. I mean, I think in terms of where I would see the greatest need for at the moment in terms of new developments, particularly in high grade, is whether there's a place for the tyrosine kinase inhibitors, so drugs like cabozantinib and lenvatinib. Now, it may be that they are more effective at the lower grade end of the spectrum, but higher grade tumors will tend to have a high, or more likely to have a higher tumor mutational burden, what's known as a TMB. And it's in this group that theoretically the checkpoint inhibitors, which again are another new group of, or relatively new group of drugs, may be more likely to be active. And there is some suggestion that these checkpoint inhibitors may be better when you've had chemotherapy first. I'll probably say something that the clinical scientists will freak out at, but if you like, it tickles up the immune system. There seems to be some evidence that giving chemotherapy first does something to your immune system and makes you then more likely to respond to a checkpoint inhibitor. Whereas it looks as though if you are given a checkpoint inhibitor as a naive, as a chemotherapy naive patient, in other words, as you know, before receiving any other treatment, they may be less effective. But the radiation and chemotherapy seem to do things to our immune system that may allow us to respond better to these drugs. And this is where I think the clinical trials are needed to try and tease out in which situation that's more likely to occur. That's probably one of the most, I think, exciting ways forward. There are a whole host of these new drugs. And of course, the other thing is combining them. And if we take the example of melanoma, advanced melanoma a few years ago was a death sentence. And now we see that combinations of checkpoint inhibitors can lead to significant numbers of patients with very advanced disease having what we call durable long-term responses. And some of them haven't yet relapsed. So, there's lots of exciting things to be done if we can afford it, and if we've got cooperation from the pharmaceutical companies. But again, because nets and necks are relatively uncommon, they don't get megabucks back. They don't make big money out of it. So their focus is more on breast, prostate, lung, colorectal, because these are the common cancers where the returns commercially are more successful. But we can get spin-offs from them.
Previously, we were talking about how neuroendocrine carcinomas may benefit more from chemotherapy, which is, you hear more often being used for common types of cancer. So in this sense, should a patient see an oncologist if they have high-grade disease instead of a neuroendocrine cancer specialist?
Not instead. We work together. Now, it will depend very much upon the way the service works. Now, the UK is extraordinary in that we have more centres of excellence, the ENET centres of excellence, than any other country in Europe. I should know the answer to this because I'm an auditor for this. I can't remember whether we've now gone up from 13 to 15, but we did. I think the last time I counted, there were 13 and scattered around all of the UK.
We have a list
and if we include
the
Republic of Ireland as well, so Belfast, Dublin, Cardiff in South Wales, Glasgow in Scotland, ranging from Newcastle down through the major hubs in the north of England, the Midlands, down to the south coast. We are very, very well organized in that respect. I think great credit goes to Martin Kaplan really for setting this up. But within your specialist center, you will be looked after by a team, and that team will include it won't just be an oncologist or a gastroenterologist. In some centers it's led by an endocrinologist, in some centers it's led by nuclear medicine, in some centers it's surgeons. But we all work together, and if there's uncertainty, we rediscuss the case at the MDT. Everybody gets their penny worth and says what they think is the right treatment, and then hopefully consensus is reached. So I don't think patients in the major centers should be concerned that they're not getting expert opinion. I think if there is a concern, it may be where a patient is seen in a smaller center where they're obviously seeing fewer patients. That then again doesn't mean they don't have the expertise, but I think if you're particularly away from the ENET centers of excellence, the likelihood is that there will be a smaller team, but they usually will work closely with their big brother or their neighbors, and will have access to the specialist input there. So a patient shouldn't really be worried about that, because it is along with sarcomas, I think neuroendocrine tumor management has the most truly multidisciplinary. The number of specialists involved. It would take me a minute to rattle off all the different specialists involved. It is, and that is a very positive and constructive fact.
So thank you so much, Professor Reid, for taking the time to answer these questions today. And for those watching, I hope this whistle-stop tour of high-grade neuroendocrine cancer will be useful. For those interested, this Q&A session is part of a series where I speak to various medical experts covering a range of questions. So keep an eye out for those. But thank you again, Professor Reid.
Thank you very much. It's been a pleasure, and I hope I haven't confused you all, but there are areas within this where the terminologies have been quite complex, and hopefully we've tried to unravel it a bit.